crumbs, diabetes. What's diabetes got to do with tuberculosis? But actually, it's got to do quite a lot with tuberculosis, particularly in China, particularly in India, and I think it's a growing problem also in Africa and other parts of the world. So my presentation, which will be about 25 minutes, and please, if I'm going through and you don't understand something, just, we know each other now, just ask me questions, all right? I think we're a family now, so don't feel embarrassed. But I want to say something about the epidemiology of the two diseases, the importance of diabetes, the importance of tuberculosis worldwide, and then how these two diseases interact. I want to tell you about a WHO and union. I work for the International Union Against TB and Lung Disease. The WHO and union, what's called Collaborative Framework for Care of Diabetes and Tuberculosis. This was a document launched a couple of years ago. I want to explore with you some challenges for care and show you some of the work that we've been doing in China and India. And finally, I want to wrap up. So let's start by looking at diabetes and TB. They're both very ancient diseases, what we call diseases of antiquity. So diabetes you can see mentioned in classical literature about 1500 years BC, so that is 3,500 years ago, and you can see the same for tuberculosis. If we just look on the left with diabetes, there are three main types of diabetes. What we call type 1, type 2, and gestational. Type 1 diabetes means you have no insulin. Insulin is produced by an organ called the pancreas, which is in your abdomen, and it stops producing insulin. And basically, if you don't have insulin, you will die of diabetes type 1. Type 2 is the most common form of diabetes we have in the world, and is essentially because of resistance of the body and of the cells to the action of insulin, which allows glucose to get into the cells. And finally, gestational diabetes, this occurs in pregnant women. When they have their baby, it goes away, but this is a risk factor for diabetes subsequently in life. To make the diagnosis of diabetes, you basically have to have some form of blood sugar measurement. And usually we do what's called a fasting blood sugar. So if I was to have a fasting blood sugar test, what I would do is starve from tonight, and in the morning somebody would take my blood test, and if it's above a certain level, I would be diagnosed as having diabetes mellitus. There are other ways, but that is the usual way by which people make the diagnosis. We can discuss a little bit more later. And in terms of treatment, it's diet. We ask people who are overweight to lose weight. There are drugs to reduce the amount of glucose in the blood, and of course insulin. And essentially with diabetes, this is treatment for life. Okay, Lottie, I was just going around, so you are from?
I'm from Lok Sabha TV, India.
India, very, very good, thank you. So with tuberculosis, you've been hearing a lot about TB. I think you're much more expert on TB than I am now, in fact, after 1.5 days of lecturing and discussion. But I would classify TB in three ways. Sited disease, is it in the lungs, pulmonary, or outside of the lungs, which we call extrapulmonary? Have you confirmed it by either finding the TB germs on a slide or by growing TB germs in culture, or is it just diagnosed because I think, Lottie, you've got TB, all right? And is it drug sensitive or drug resistant, all right? And as you know, as you've probably heard, we have an epidemic of drug resistant tuberculosis. Finally, diagnosis, despite what you'll hear about all the innovations in the world, still throughout most of the world we make the diagnosis on a sputum smear looking for germs under the microscope. It's called sputum smear diagnosis. And treatment for basically drug susceptible disease is 6 months of treatment with 2 months of 4 drugs and then 4 months of 2 drugs. You all know about this, yeah? Are you all expert now on TB? If I gave you an exam on TB, would you get 100%? I bet you'd do pretty well. I bet you do pretty well. Now let's just look quickly at global burden. So diabetes, a big problem. 366 million people estimated to be living globally with diabetes. 10 million new cases every year, so that global burden increases every year. And nearly 5 million deaths each year due to diabetes. That's a big attrition globally from a single disease. You know the latest data on tuberculosis. This is data obviously from 2011. We have new data for 2012, but actually it's not a lot different. I think, Linda, these slides are available for everybody. Yeah.
They will be on our website for everybody by tomorrow.
Exactly. So they're all there for you. Now, if you look on the right here, tuberculosis, we all know, is essentially a disease commonly seen in LIC, MIC. What do I mean by LIC, Alina? What do I mean by LIC? Low income country. Yeah, MIC is middle income country. That's right. Okay, so our common abbreviation. Yeah. But interestingly, 80% of diabetes in the world also occurs in low-income and middle-income countries. So that's where the great burden resides. And India and China. So I'm glad we've got representatives from India and China here. So let's look at India. You are the second highest capital of the world for diabetes, right? 60 million diabetic patients in India. And you're, of course, the capital of the world for TB. No country in the world has more TB than India. So 2.2 million TB cases per annum. China, where are my Chinese colleagues? You are the capital of the world for diabetes. Yeah, at 90 million, and people say that's an underestimate. You're over 100 million with diabetes. Okay? And you're the second highest capital of the world for TB, at 1 million TB cases a year. So India and China really have a big problem when it comes to diabetes and tuberculosis. Of importance, if we look on the left, half the people in the world have diabetes and they do not know they have got it. All right? And they don't know they've got it until they develop a severe complication. That complication being a heart attack from which they can die, or kidney disease, or basically a leg amputation because of an infected foot. Equally though, and I think you've heard this yesterday, about a third of our TB cases in the world are not notified. We don't know what happens to them. We think in India, a lot are treated in the private sector and not notified. But how well they're diagnosed, how well they're treated, we don't really know. And finally, TB, the good news is it's going down, all right, at 2% decline per year. Diabetes, on the other hand, is going up, all right? So this is what's predicted. By 2030, we will have 500 million people out of what? 8 billion, perhaps, living with diabetes in the world. So we have a global epidemic of diabetes on our hands, and India, China, you are the countries leading this epidemic. Africa, don't sit back and say, oh, we're going to be all right. Africa's got a growing epidemic of diabetes as well. Now, let's look at the interaction between these two pathogens, or these two diseases. We have about 2 billion, I saw just in this symposium I was attending, 2.3 billion people carrying Mycobacterium tuberculosis in their bodies, all right? Now, those people, most of them, do not get tuberculosis, all right? They carry TB germs, they don't get tuberculosis, all right? You might say, where do they carry those germs? Probably they carry them in the lungs. Yeah, I saw research done on this, I remember 10 or 15 years ago. But it stays under control. But 5 to 15% get active tuberculosis sometime during their life. Now, there are risk factors for getting active TB. So when you're a little child, an infant, you have a high risk of getting TB if you have the germs. And when you get old, you have a high risk of getting TB. And that's going to be very interesting in this world, because now, instead of dying at 60, 50 years ago, I shouldn't be here. I'm just over 60. I should be buried and resting in my resting place. But now we live to 80, 90, and maybe in 30 years' time, Some of us will live to 100, yeah? And as we get older, our immunity goes down, we're at risk of getting tuberculosis. HIV/AIDS is the strongest risk factor known to man. There are other causes of immune suppression. Do you know steroids? Have you all heard of the drug steroids? If you take steroids and you've got TB inside you, you can get active TB. And then silicosis, which is a disease you get from working in mines, malnutrition, smoking, alcohol, and diabetes is there as well. So let's look at this interaction between diabetes and TB. Now, very interestingly, if you look at the classical literature from the Romans, how many of you know about the Romans? Yep, good, Wycliffe. Anybody else know about the Romans? They lived in Italy, and they were an amazing civilization, the Roman civilization. They built incredible things, and they conquered Europe, conquered a lot of Asia. I don't think they got to China, and I don't think they got to India, right? But in my country, England, if it hadn't been for the Romans, we would still be living in huts, I think. Yeah? They civilized us in England, so we're told. Yeah? But they recognized this association between diabetes and TB. They wrote about people who passed a lot of urine. If you have diabetes, one of the symptoms is you pass a lot of urine. And that urine, if you taste it, is sweet. Now, not many people, of course, taste their urine, but you know, you can do if you're a scientist, and it's sweet. And they wrote about people passing urine, sweet urine, who were at risk of getting a disease, coughing up blood, losing weight, probably tuberculosis. Now, from the Roman times, up until about 5 years ago, there were a few people writing about this link, but not very much. This was the seminal breakthrough. So if you're ever going to report about this, these two great people, Christy Gion and Megan Murray, wrote a paper in PLOS Medicine looking at the global literature about whether diabetes and tuberculosis were linked. And amazingly, all they could pull out of the global literature was 13 observational studies. Is this no, okay. Is there a pointer? Yeah.
Yes, in the upper right corner.
Upper
That
right.
little silver button.
The silver button, this one. Okay, so here, 13 observational studies, all right? We won't go too much into the science, but they were what's called cohort studies, case control, and other studies. And basically, in these 13 studies, they had about 1.7 million participants, of whom 17,600 developed TB. And to cut a long story short, they found that diabetes was associated with an increased risk of tuberculosis. In the cohort studies, which is when you follow a group of people from the start forward, so for example, you could be a cohort of journalists coming to this course, and in 5 days' time, you're a group, we could do an exam and say how many of you passed the exam, yeah? And if 80% of you pass, that's a cohort study. You with me? So the cohort study showed that the relative risk of being diabetic and getting TB was 3.1, meaning that a diabetic patient is 3 times more likely to get tuberculosis than a person who does not have diabetes. Everyone clear on that? Yeah? Yeah? Clifton, you okay with that? Yeah? And then the case control studies, very simply, are where you take people with TB who haven't got TB and you see who had diabetes, who didn't, and what's called an odds ratio varied from 1.2 to 7.8. So meaning that you were 1.2 times to 7.8 times more likely to get TB if you had diabetes. So a little bit of variation here, but definitely an increased risk. Now, I just want to mention this other person who sadly now died, Catherine Stevenson, who worked in WHO. At the same time that Christy Gion and Megan Murray published their study, Catherine Stevenson in WHO did similar studies, found similar results. And she also looked in India. So my Indian colleagues, let's just go through this. They looked at India for the year 2000. And in the year 2000, it was estimated that India had 21 million adults with diabetes and had 900,000 new cases of TB. You think what India is like now? Yeah? Really gone up compared with that. And they did epidemiological work, and they reckoned that diabetes accounted for 15% of pulmonary TB in India and 20% of smear-positive pulmonary TB. Meaning if you didn't have diabetes in India, you'd have less tuberculosis. With me? So in India, big issues. So I think we conclude by these studies, and then there's other studies in red I've highlighted here, that diabetes increases your risk of getting TB by a factor of 2 or 3 times. And I'd just like you to look here, that there's some evidence that if you have diabetes and your diabetes is poorly controlled, meaning you have high blood glucose levels, you are at more risk of getting tuberculosis. It's very similar to HIV/AIDS, for instance. If you have HIV/AIDS and you have very bad immunity, you're at risk of getting TB, compared with if your immunity is better. Everyone happy with that, yeah? Now, is this biologically plausible? Meaning, does this make sense? And the answer is yes, it does make sense. You can make mice diabetic. I'm not going to tell you how, but you can. In fact, it's not very nice on the mice, I think. However, you can do this. And you find that diabetic mice have impaired cell-mediated immunity. Now, we all need what's called cell-mediated immunity to protect us against various things, especially TB. So if you give those diabetic mice an injection of Mycobacterium tuberculosis, you find they have much more TB than mice who are not diabetic. Everyone clear on that, yeah? So in the mouse model, diabetes increases the amount of TB in the mouse. Also, people have done work on patients with diabetes and found that basically their immune systems do not work as well, and the immune systems needed to control TB are badly functioning. So they're at risk of getting TB. And finally, diabetes is associated with these 3 problems here. Diabetes causes that horrible name, pulmonary microangiopathy. Look at it and forget it. It basically means it interferes with blood vessels supplying the lungs, and those blood vessels supplying the lungs, that condition makes you prone to getting TB. It gives you kidney failure, and if you have kidney failure, you're at risk of TB, and it gives you micronutrient disturbances. So all of these factors increase your risk of TB as well. So, there's no doubt there's an association, and it makes sense. But there are problems around this. Many of those studies that led to these conclusions came from what we call industrialized countries. Many of them were hospital-based studies, and there are many unanswered questions. And as a result of this, in November 2009, here in Paris, we were asked at the Union to convene a global meeting of WHO. WDF is the World Diabetes Foundation. IDF is the International Diabetes Federation. These are the 2 big bodies that look after diabetes on a global level, a bit like who looks after TB on a global level? My mind's gone blank. WHO, CDC, yeah? Global TB Alliance, yeah, like that. And then academia and ministries of health. And one of the purposes of this meeting was to look at the evidence and to see whether a global document could be put together that advised countries how we should manage these 2 diseases together, all right? And what happened was that a framework was developed. Now, as journalists, you might ask, what do we mean by a framework? When WHO thinks about giving guidance to countries, it says either we will give guidelines, which are quite specific recommendations backed up by evidence, or it says we don't have enough evidence for those guidelines, and we will give a framework. We will give an overall view of this is what should be done, you with me? And we will try and collect evidence to make these guidelines in the future. And this is what happened with this document. It was felt that there was not enough evidence to make guidelines, but there was enough evidence to say this is an important problem and we will put together a document. So this was launched in 2011. This is what the document looks like. You can download it from the WHO website. It's about 36 pages long. I think all these documents, if I'm really honest, are always too long. Yeah, they should be shorter. I see you nodding, Pradeep. I quite agree. I've been involved for many years. I worked in Africa for many years, but I was involved with WHO for many years. The best document we ever put together was the first WHO TB HIV policy document. I was chairman of that group. I had a great group of people, and it was a 16-page document, finished. Yeah, and it was widely implemented. Now they had a revision of that document last year. It's now 38 pages. It's not too bad, but it's too long. I honestly think that one needs succinct stuff to say, this is what we think should be done, and here's briefly the evidence to support it. Very quickly, what does this framework say? It says three things. A, it describes how the diabetes world and the TB world should come together and collaborate. And I'll just let you look at that. I won't say anything more about it. Secondly, it discusses how in patients with diabetes we should screen, detect and manage tuberculosis. And I'm going to show you some examples of this from India. And finally, it says in patients with tuberculosis how we should detect and manage diabetes. Everyone clear? It's very similar to what you've probably heard about on HIV TB. Has someone talked to you about HIV TB? It's exactly the same. You know, with HIV TB, you want to know how do the two communities work together? How do we screen HIV people for TB? And how do we screen TB patients for HIV? It's exactly the same way of thinking with diabetes. Okay? So let me take you through three challenges for care. The first is on screening. So here it's important that we think about screening TB patients for diabetes. Now the important thing is we can't just, if you had TB, Biswajet, I can't just ask you, Biswajet, do you have diabetes? Do you have, you're passing too much urine? It's too insensitive. We have to do some form of blood test because it can't be recognized clinically. So that immediately complicates things if you imagine trying to do this at a primary rural sort of setting. Similarly, in screening diabetes patients for active TB, TB presents differently. You heard that with HIV. HIV suppresses your immunity. TB does not look the same in an HIV patient as in a normal patient. The same applies to diabetes. Right? So that's two immediate problems. Having said that, I just want to draw your attention to the fact that there's been quite a lot of work done on this in 2011, 2012 in various countries, and I just highlighted some here. In Texas and Mexico, they did some screening work, and that's very high. 36%, 39% of TB patients screened for diabetes had diabetes, 2 times higher than the normal population. Nigeria, Tanzania, so my African colleagues, this is an African problem as well as an Asian problem, yeah, although maybe not to the extent. And look in India, Karnataka, Kerala, 44%, 32% of TB patients had diabetes. In the South Pacific, a major, massive problem. Yeah? So wherever we look for this, it seems there is quite a lot of interaction. Now, I want to quickly take you through some work I was involved with in China and India. So it'll be of interest to my China-India colleagues, also to those of you not in those countries. And I think what we did was quite good. I'd like to just describe it. We decided, as a result of the framework, we ought to see if we could do what's called bidirectional screening. So we started with a national stakeholders meeting. Went to both countries, we have our connections, and the directors of the NTP, the directors of the Diabetes Non-Communicable Disease Program, the professors, the experts, we got together and decided how are we going to screen, How are we going to record? Where are we going to do it? And how should the whole thing move forward? We then trained the implementers, the people who were going to actually do this. It's not research, it was implementation. I said, listen, this is how you're going to screen people, this is how we want it all registered and recorded. We then let people do it for 8 months. We then came back, had a meeting of the implementers, we reviewed what had gone on, what were the challenges, what were the data, and finally we presented back to the people in charge. I think it's a very nice model for doing things, actually, because right at the start, the people in charge are involved, and if they think at the end, this is important, then actually you get policy change. Yeah? If you don't involve national leaders, it takes a long time. So I've learned a lot in my life that you really, if you want to get things moved in this world, you start high up, get those people involved, get them committed. Yeah? So let me show you in India what happened. Now this was how we screen people. So let me just take you through this. So you come in as a TB patient. Let me suppose you're all TB patients, all right? So we set up what we call a register next to the ordinary register, parallel register. And Elena, you would be in the TB register with a number 1101, all right? And you'd be in this register as 1101, so I can link you. With me? We were interested in smoking, so I ask you, do you smoke, yes or no? No. Do you have diabetes, yes or no?
No.
You don't think so. So she says no. So she says no, tough, she's going to have a blood test, right? So we now say we're going to screen you. Now the problem is, Elena's come in the morning and you've had breakfast. So we can't do a fasting sugar, a fasting blood glucose. So we're going to do what's called a random blood glucose. I'm going to take your blood, I'm going to test it, and if it's below a certain level, I know you can't have diabetes. If it's, however, above a certain level, you might have diabetes. I don't know. So if you like, it's a sort of screening test. So I'm going to screen you with an RBG. Everyone happy? RBG means random blood glucose. And in this column here, there's the result of your random blood glucose. If it's above a certain level, I'm going to ask you, Elena, to come back in a week's time fasting for a fasting blood glucose. All right? And if it's above a certain level, I'm going to either diagnose you or not diagnose you as having new diabetes. Is everyone happy about that? And then if you've got diabetes, I'm a TB guy. I don't really know how to look after you. Actually, I should know how to look after you, but I'm going to refer you to the diabetic clinic. Is everyone clear? This is what we set up in both India and actually in China as well. And just for the sake of time, I'm just going to take you through the India work. So let's look at this in India. So 8,000 TB patients. Let's suppose that you're all part of this cohort, all right? Now, 8% of you said, I know I've got diabetes. Quite a lot of people are already known to have diabetes, okay? Leaving 7,587 needing to be screened. Now, not bad. If you follow these rows down, you can see that 98% actually had a screening test done. This is not research, this is routine services. Many of these services at health centre level. Actually, pretty good. I think India did a very good job here. Of those having an RBG, you can see that 2,838 needed a fasting blood glucose. And actually, 2,700 had it. So Elena came back for her test. Biswajet, you decided no. I'm not interested in this, and I was staying away. Well, I'm joking, all right? Now, of the 2,700 who were screened, 402 were found to have diabetes. So Elena, supposing it was you said, no, I don't have diabetes, we've tested you, boom, we've made a diagnosis of diabetes. You're one of those half the people in the world who didn't know they had diabetes until we actually tested you, okay? You follow this through then, 13% of these TB patients had diabetes and most were referred to care. Now, this actually I think was quite impressive. I think India, also just to say, my colleagues in China did a very good job as well with this. But India moved quicker than China in terms of policy. the two big chiefs got together and said, we have a problem, yeah? A problem here, and we think that all TB patients in India need to be screened for diabetes. And a directive went out around the country to basically do this. That's a lot of testing. 2.5 million TB patients every year, all of them going to be tested for diabetes, going to cost Lottie India a bit of money. Yeah? So obviously you've got to think about that, you know? Where's that money coming from? What I've just taken you through is too complicated for routine use. So the Indian National TB Control Program, called the RNTCP, Revised National TB Control Program, said all we want to know every 3 months is the number of TB patients registered, the number screened, and the number diagnosed. We don't want to go through all this RBG, FBG business. Just who was screened, who was diagnosed. It's like HIV testing. Who was tested and who was positive. Okay? And India was great. This is their treatment card, and you can see down here at the bottom, this is their HIV bit, okay, for which they produce global data. They've added in diabetes now, so India will report routinely on diabetes data. In the register, they've now, instead of having a parallel register, we're going to make this simple. So here's the HIV information, here's now the diabetic information. Simple as that. And India produced a national manual for basically training. So India did a very good job. In China, you were a little bit slower with policy, right? Decided, yeah, we impressed with this evidence, and what you said, or what your big bosses said to the people was, in the sites where they were implementing, continue. Let's expand in some other sites, but we're not ready yet to make a policy decision. Fair enough? Yeah? It's just different ways of addressing a problem. Yeah? Let's look at it the other way around. So it works well, TB patients being screened for diabetes. Now what about screening diabetes patients for tuberculosis? So how are we going to do this? So what was decided was this, that every time a diabetic patient comes to the clinic, we will screen them for TB asking about symptoms. So let me ask you, what sort of symptoms do you think we'd ask the diabetic patients? You're TB experts now, so what sort of things, Clifton, let me put you on the spot. If I'm a diabetic patient coming to your clinic and you're screening me for TB, what do you think you should ask me to screen me for TB? What do you reckon? Okay, you don't have to answer. Anyone like to try and answer?
How thirsty do you feel?
No, this is not diabetes. This is, you want to see whether I've got TB.
Oh,
Whether I've got TB or not.
cough.
So have I got a cough?
Yes.
Yeah. Have I lost weight? That's right. Have I got a fever?
Yes.
Have I got night sweats? That sort of thing. All right. So that's right. So these sort of things we decided slightly different from India and China on the sort of questions, but everybody was asked about cough, weight loss, night sweats, fever. And if they said, yeah, I've got a cough for 2 weeks, they were referred for TB investigations. Everyone happy with that? Yeah? I didn't get, I think, Mara, where are you from?
South Africa.
South Africa, welcome. Good. And I think, did I get your, yeah. Yaru, where are you from? China, okay. Very good. So mainly here it's China, India, South Africa, Malawi, Kenya, and Pakistan, right. I'm sorry, Russia, of course, Russia, yeah. Of course. So, that's right. Okay, very good, yeah. Okay, the BRICS nations, yeah. Malawi, you're a BRICS nation. And Kenya. Okay, this was the treatment card we used. I won't dwell on that. I'll show you how it worked out. It didn't work very well. Right. So this was India, second quarter of 2012, 12,000 diabetic patients seen in the various diabetic clinics. Okay. Now very interestingly, during that quarter 2 means April the 1st to June the 30th. Okay. During that time, 74 diabetics said, I've been diagnosed in this quarter with TB. but not from your clinic, but from outside. India's got a very, very good network of TB diagnostic centres. So I presume these patients have had a cough, weight loss, and have gone somewhere and been diagnosed with TB. So 74 people diagnosed with TB outside of the diabetic clinic. The rest should have been screened, and you can see that 6,300 only were screened for TB symptoms, about half. So the other half, the diabetic doctors didn't do it or didn't record it. Okay. If you look down, only 135 had symptoms. Most of those were referred for investigation, and 11 were found to have TB. It's about right. If you have 10 people complaining of cough, fever, weight loss, night sweats, you'll probably find tuberculosis in about 10%, 10 to 20%. So this is about right. So altogether, we found here 85 patients with TB in this diabetic group, which if you do per 100,000 is quite high, 695 per 100,000 in a quarter. Generally, India has about 100 per 100,000. So actually, this suggested to us it is worthwhile activity screening diabetic patients in diabetic clinics for tuberculosis. Everyone with me? You're going to pick it up. But diabetic clinics are not used to this. They're not used to recording things. They don't have a public health mindset. Okay? So this is why it didn't work quite so well. So just a few questions here. This data needs to be looked at much more individualized. We need to work out smoking and diabetes. Smoking is a risk factor for diabetes. Lottie, if you've got diabetes and you're a smoker, you are 5 times more likely to get TB than somebody who doesn't smoke and doesn't have diabetes.
Thank God I don't smoke.
What?
So thank God I don't smoke.
Yeah, thank goodness you don't smoke. Bradley, if you smoke, have diabetes and drink lots of alcohol, woo, you're in problems. You're 7 times more likely to get TB. And so, what?
Last month I actually checked for the disease whether I'm there or not.
Yeah.
Actually, there's no reason.
You're all right. Very good. Very good. Keep checking, all right, because it changes as life goes on. We need to work out cost-efficient screening. When is the best time? Better data management systems. I'll leave that. But there are a lot of questions around this which still need to be answered. Secondly, I've got about 5 more minutes, so it won't take too long. If you've got diabetes and you have tuberculosis, is it a problem? And the answer is we think it's a problem, all right? For 3 reasons. First of all, it takes you longer to get rid of the TB in your body, meaning there's a delay in what we call sputum culture conversion. You with me? So if I got TB, I have a positive sputum culture, and my TB grows on a Petri dish in the lab, and I'm on TB treatment, very rapidly my sputum becomes negative. It takes longer to become negative if you're a diabetic patient. Okay? Secondly, if you're a diabetic patient, you have a higher risk of dying on TB treatment than if you're not a diabetic patient. Okay? And thirdly, if you have diabetes when you have completed your treatment and you're better, you have a much higher risk of getting TB again, what we call recurrent tuberculosis. Now, I'm not going to show you these studies. Let me whisk through those. Basically, what I've said to you is what these studies show. You might ask, why is there an increased risk? And there's 4 reasons. First of all, the drugs used for treating diabetes interact with the drugs used for treating tuberculosis. Rifampicin and the oral diabetic drugs cause each other's concentration to go down, so they're not effective. So that's one reason. Secondly, diabetes, for some reason, is a risk factor for increased liver toxicity with TB drugs. This is a difficult question. What are the 4 main TB drugs? Anyone like to answer that? I think you do have, Linda, is there an exam for various? So I'm really helping you with your exam now. Yeah? You've got an exam in 3 days' time. Yeah? If you pass the exam, you stay on. If you fail the exam, you're sent home. I'm joking. Yeah, tell me what the 4 drugs are.
Isocyanide, rifampicin, ethambutol, and I don't know the fourth one.
Okay, you're doing pretty well. You're doing very well. Anyone like to come up? So, isoniazid, yeah? You slightly mispronounced. Isoniazid. Isoniazid. Very good. Okay, I think you said isosniazid. But it was very good. They're very difficult, these names. They're very difficult. So, isoniazid, rifampicin, okay, pyrazinamide is the one you didn't mention, and ethambutol. Yeah? Okay. Now, very difficult question. 3 out of those 4 drugs cause liver problems. Do you know which they are? Isoniazid, yeah? Anybody? I think it would be very tough if you were asked this question, actually, but just in case. Okay, so isoniazid's liver toxic, rifampicins liver toxic, and pyrazinamide are liver toxic. Meaning, if you take those drugs, you can go yellow, you can get jaundice, which is a manifestation of liver toxicity. Diabetes increases that risk of getting liver toxicity, and that jaundice can kill you. All right? Why people die sometimes from TB drugs is they get what's called acute liver failure, and they die of liver failure. Thirdly, diabetes suppresses your immunity. Okay, so that may make you die during treatment. And finally, this is an interesting one. We have diabetic clinics. Supposing we're all in a diabetic clinic, we're at risk of getting TB, but like Eleanor, she doesn't know she's got, well, sorry, that's the other way around, wasn't it? But supposing you're coughing, Eleanor, and nobody thinks of TB, then it could be that in the diabetic clinics, TB is being spread, just like it gets spread in HIV clinics. So nosocomial, it's a word we use for basically in health centre, hospital settings, spread of tuberculosis. Everyone with me? So these may be reasons why, in fact, there's an increased risk of things not going well on TB treatment. Again, many questions. We don't know if your diabetes control is out of control. Does this affect TB treatment outcomes? I would assume it does, but we don't know. Is 6 months TB treatment enough? We do not know the answer to that. In America, the CDC guidelines say, CDC is Centers for Disease Control, say you can treat for 9 months if you want. But where's the evidence? We don't have the evidence. When do people die who have diabetes and TB? We don't know. Do they die at the beginning, at the end, in the middle? Why do they die? How do we prevent death? And when they get recurrent TB, the big question is this because we've not got rid of the TB in the body, or is it because they get a new infection, maybe from a diabetic clinic? So lots of questions we don't know. And finally, my final challenge on this is, what about preventing tuberculosis and diabetes? Now, I think you probably heard, if you have HIV, you can take isoniazid preventive therapy. Has anyone talked to you about that? No? Is there a session on HIV-TB? It didn't talk about that. Okay. So anyway, it's one of the factors to be considered. If you have HIV, to take what's called isoniazid alone to stop you getting tuberculosis. Now, again, CDC recommends if you've got diabetes, you should be considered for isoniazid preventive therapy. Okay? So, Eleanor, if you've got diabetes, think about giving you isoniazid for 9 months. What's the evidence? 2 studies. One in 1958, done in Germany, and one in 1969, done in Russia, done in your parts of the world, and people didn't do very good studies in those days, so no disrespect to Eleanor, what's her first name? Yeah, but they were really not the greatest studies, these, yeah? They weren't what we call randomized controlled trials. So the evidence for the use of TB preventive treatment is very little, yeah? Problem is, to do these randomized controlled trials nowadays costs a huge amount of money. So the question will be, are we interested in doing it or not? And I think at the moment, there's no interest. Yeah? So let me just summarize this. Got a couple more slides and then we'll chat. diabetes TB is very, very similar to HIV TB, all right? Both sides, we have increased numbers of TB cases, right? Diabetes increases the risk by 3 times, HIV increases the risk by 30 times. So HIV is more serious at an individual level. But don't forget, we have 30 million HIV-infected people in the world. We have 350 million diabetic people in the world. If you look at a population effect, it might be similar. The TB cases are more difficult to diagnose because of reduced immunity. There's an increased risk of death in both situations. There's an increased risk of recurrent TB, meaning you finished, I'm better, and you get TB again. HIV and diabetes increase that risk. And finally, there's an increased risk of failure. This has just come out, so that you're on TB treatment and you don't succeed in curing the organisms. So finally, what do we need to do? We need to tackle these issues and we need to deal upstream. And again, with HIV TB, I've always firmly believed we will never get on top of it until we control HIV. That means behavior, it means condoms, it means male circumcision to protect the males, much earlier use of antiretroviral treatment, and there's now good evidence that ART, antiretroviral treatment, prevents transmission from an infected person to a non-infected person. Diabetes, it's very different. It's all about lifestyle, all right? Healthy diets, okay? So no Coca-Cola, no Big Mac, cheeseburger, double size. Exercise, all right? Lots of walking, lots of exercise. Tackling obesity, yeah? Obesity is a big problem. Obesity leads to diabetes and early detection of where it's going wrong. So if I just sum up then, we have with this growing epidemic, a growing pandemic. Pandemic means worldwide epidemic of diabetes. No doubt this is a big problem. It's going to face us in the next 10, 20, 30 years. We believe in the TB world that this could threaten TB control, all right? By increasing the number of cases, by increasing the case fatality, and by increasing the amount of failure and relapse. And finally, we need both the diabetes, the non-communicable disease body, and the TB bodies to start working together, and we need evidence to know how best to work together. So I'll finish there, and be very happy to try and answer any questions that you may want to ask on diabetes and TB. Thanks.
Some of you may want to refer to your quiz and ask them some of the quiz questions.
Oh.
But Svetlana, please go ahead.
Anthony, thank you for your presentation. It was very impressive. And the connection with the audience is very good. You said that when you have a blood test and you are going to the certain numbers, so you have to think about diabetes. And what are the numbers? What are these certain numbers?
Thank you very much. Thank you very much. I didn't. I got them. Let me just take you to them, if that's all right. Is it Svetlana?
Yeah.
Yeah. Let me take you to them, Svetlana. Basically, random blood sugar. If it's more than 110 milligrams per deciliter, that means it doesn't mean you have diabetes, all right? It means you're a potential risk. So if it's below, supposing Lottie is 90, I can safely say, Lottie, you do not have diabetes, you do not need a fasting blood glucose. But supposing, Svetlana, you are 115, then all I can say to you is, you might be at risk, we don't know, we need to do a fasting blood glucose on you, all right? So then I'd bring you back to do a fasting blood glucose, Svetlana, and if it was above 126 milligrams per deciliter, this is how in India they use milligrams per deciliter. In China, you use millimoles per liter. Yeah, we use that in the UK too. And 126 is the same as 7 millimoles. So basically, if you were above 126, I'd say to you, Svetlana, you have diabetes. Now what should happen is that I would refer you to a diabetic clinic, they would repeat that test. So actually, you don't normally say you have that disease on one test only. You do it on 2 tests, because it's you know, not very nice to be told, crumbs, I've got diabetes, you know, now you've got to alter your lifestyle, blah, 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 you may have to take tablets for the rest of your life. You want this to be correct. Yeah? So normally it's done twice.
And can you rely just on these home little devices where you can measure your blood?
They're not bad. They're not bad. WHO says that the home-based, it's what's called a capillary blood. So if I take my little lancet, I jab my finger, put that drop of blood on a test strip, dry it and put it in a machine, press a button. Result, yeah? So it's not bad. It's not bad. You have to make sure you calibrate that machine, meaning every day you put a control test strip in to check that it's reading correctly. Yeah? But it's pretty good. WHO says the capillary blood tests are the same as venous blood tests, and we're happy to accept them. So interestingly, in India, the Indian government decided to do this on capillary blood tests. In China, it decided not to. Decided to do it by having a blood done in a laboratory. Problem with having it done in a laboratory, that sample's got to get to a laboratory and you've got to get a result back. Much easier having a machine. Yeah? But it's a very good question, Svetlana. So let me just take you on with this. So I do your tests, all right, and I find you have a fasting blood glucose of 130. Okay? Svetlana, very sorry, you have diabetes. Eleanor, I do a test and she has a fasting blood sugar of 110. Svetlana, you're fine, don't worry. I'm wrong in telling Elena, I'm wrong in telling you you're okay. Because there are more sophisticated tests, and in fact, the fasting blood glucose misses quite a bit of diabetes. So this is an issue. So I don't want to complicate things, but you need to know the truth, right? So Sean, in China, they did a very big screening of China's population about 3 years ago. Tested 50,000 people in China, right, on a fasting blood glucose. They also did a more sophisticated test, which is called an oral glucose tolerance test. And just to explain that, I would say to Lottie, you have Lottie coming in fasting, I'd then get Lottie to drink 75 grams of glucose. I'd done one of these horrible. I'd drink it all down, and then I'd measure your blood glucose 2 hours later. It's called an oral glucose tolerance test. It's meant to be much more sophisticated. In China, they found that half the people, they found that they diagnosed diabetes in so many people, and they found that in an equal number of people said to be normal, actually they had diabetes on oral glucose tolerance testing. So what I present you in India, these results in India, 13% is an underestimation. Yeah? So probably we have to just bear that in mind, and probably one needs to say, well, okay, you're all right now, but maybe these people should be tested again in 5 years' time. Yeah?
Well, hereditary has a role to play in diabetes.
Sorry?
Heredity, you know?
Heredity, yes, no, it does.
Yeah.
Yeah.
So if my father is suffering of
Yeah.
diabetes, what are my chances of suffering of diabetes at about what age?
Lottie, they're increased. Increased for a number of reasons. Heredity plays a part, but also the environment. Your dad may have diabetes because of your dad's lifestyle. Do you know? Maybe your dad doesn't like to walk, he likes to drive in a car. Yeah? Maybe he likes chapatis made in oil or something. You know, I don't know. You're with me. So the environment also plays a part here, Lottie. So you can't mix it. But what is well known is that if there's a family history, the people in that family are at increased risk. So it's a very good point. So, you know, if I had someone in my family who had diabetes, probably a good idea for a family to get checked out. Yeah? I mean, the worst thing, because this is treatable, it's controllable.
And lifestyle modifications, I think they would go a long way in ensuring that I don't get it.
Absolutely, absolutely. You know, basically keep your weight down, eat reasonable food, make sure you take some exercise. Yeah. 3 years ago, I got involved with the diabetic community, and they were wearing. Do you know what these things are?
Yeah, I know.
Yes.
Pedometer.
Yes.
Yeah. So they convinced me.
10,000.
10,000, absolutely. 10,000 steps a day.
Steps a
Yes.
day.
So I saw a number of people where I said, "What are these?" They said, "Oh, it's our pedometer." Is it good? Yeah. Trying to get us to do exercise. It's brilliant, I tell you. I mean, I do a lot of travel, and I do a lot of work from home, and I look at this and I think, crumbs, I've done 800 steps. That's all I've done today, and it makes me get out.
Yeah.
And say to my wife, "Do you want shopping, dear?" And I'll walk to the shops. So I think it's very good. I've done 2,200 today, so I've got another 7,000 to do today. I'm not doing well.
It's a great city for it. Who else has questions, Dr. Harries? Farnas?
Yeah.
High insulin, and particularly in our parts of the world, also globally, there's incidence of PCO, polycystic ovarian syndrome, in women, increasingly of all ages. So such people with high insulin, women, are they more, their chances of getting diabetes are more. That's a forerunner, right?
High insulin, yes. I tell you how it sort of works. What happens is this, that type 2 diabetes is the common problem, right? So type 1, which is an autoimmune disease, meaning for some reason or other, the little cells in the pancreas that produce insulin get destroyed and you don't have any insulin. The other way around, what happens is that you don't exercise, you put on weight, and you become what's called insulin resistant. And as a result of that, your pancreas and those islet cells start producing more insulin to try and cope with that. But you have insulin resistance. And then eventually, in simple sort of terms, those islet cells get exhausted. Yeah? So they produce lots, and then they can't cope anymore, and then they start not producing enough, and then you run into problems. So that's how it works. Of course, measuring insulin is quite difficult. Yeah? It's not an easy thing to do. You can do it in research studies, but part of the routine system, health system, I've never, I think in my life, known how to measure the insulin. Yeah? You can measure something called C-peptide, which is a sort of marker of insulin, but you're right.
They have fasting blood insulin tests, which are quite.
Oh, really? Okay, right.
Because in Pakistan and many countries, in women, the polycystic ovarian syndrome is very common, and one of the things that women suffer from as a side effect is high insulin. It sort of goes together. So they're giving metformin for for treatment of that as well. And they warn that this might be a forerunner for diabetes. So I was wondering if such women are also more predisposed to tuberculosis.
I don't know, follow it up.
Okay.
Write a story. Yeah.
Dr. Harris,
Yeah.
I'm Maitri from India.
Yeah.
You'd mentioned right at the beginning of your class that there's a high risk of people getting TB if they use immunosuppression drugs like steroids.
Yeah.
However, related lung health conditions like asthma require the use of inhalers which have glucocorticosteroids, and therefore curing one disease or one ailment makes the person more susceptible to something like TB.
Yeah.
So how does that work?
No, you're absolutely spot on, all right? So if you've got asthma, you have to take inhaled steroids, yeah? Now the thing is that those inhaled steroids are at a sort of relatively low level, and they're confined, the steroid dose and the immune suppression is confined to the lungs, all right? So I'm talking about if you take steroids by mouth, all right, where it affects basically your immune system throughout the body, okay? But many asthmatics need oral steroids, tablets, to control their asthma. They're at risk. They're at risk of getting TB. Clifton, we have a lot of asthmatics in Malawi, right? And I remember looking after asthmatic patients in the medical wards of Queen's Hospital and Kamuzu Central Hospital. Yeah, it's a big TB environment, yeah, and those people are at risk of getting tuberculosis. And sometimes we've said, we think you are at risk of TB, so we're going to give you steroids for asthma, but we're going to give you isoniazid preventive therapy to stop you getting TB, because we think you're at risk. So not only will you take steroids, but I'll give you an anti-TB drug, yeah, to stop this happening with me. Yeah? So you're absolutely spot on. Now how much, if you take inhaled steroids, I don't know what the additional risk is. I would guess it's a little bit higher than 0. Yeah?
Any studies on that?
No, I'm not aware.
Oral?
Oral, yes, no, definitely there's studies on oral, absolutely. And I mean, I won't go. There's new forms of drugs to suppress immunity. One of these being, well, it's called anti-tumor necrosis factor. It's a sort of when your immune system is being stimulated, the cells release various things into the blood, right, which sort of protect you. One of those things is called tumor necrosis factor, TNF. Yeah? And they've got a drug now that blocks TNF, a TNF blocker. And they use it, for example, in people with inflammatory bowel disease, to control inflammatory bowel disease. But if you're on a TNF blocker, you're at increased risk of getting tuberculosis. Yeah, they realize that is a significant side effect, if you like, of this drug. So it's not just steroids, it's other things that block immune systems. I have a kidney transplant, and I have to take immune suppressant drugs to stop my body rejecting that kidney transplant. I'm at risk of TB, no doubt. Yeah? Especially if I live in a high TB burden environment, such as Africa, India, China, maybe some parts of Russia. Yeah? Yeah, sorry.
Professor Anthony, just want to ask you one straight question related to the tuberculosis and the diabetes. A country like India, tuberculosis is related to the common poor health, and diabetes is related to the lifestyle and the private So how you see the communication gap between the private setup and the government setup? Because the letter was given to only the TB centers, not to the place where most of the people are going for treatment in diabetes.
No, it's very interesting. That's a great question. That. So maybe they're poles apart, and the question is, the diabetes occurs in rich people, the middle class, TB in the poor people. Why should they be? So first of all, I think, Pradeep, that perception is wrong. Okay, so diabetes occurs in your poor, undernourished people. I was amazed. They did what WHO did a study in Malawi, in rural people, and I thought we're not going to find any diabetes. We found plenty of diabetes, undiagnosed there. Okay, so it occurs. The rich people come to diabetic clinics, hospitals. Now, I think maybe if there's TB circulating there, not picked up, they're at risk of getting it. So it's a great question, but I think your perception of the lower classes not getting diabetes is wrong.
No, I was not saying, I'm damn sure, because most of the studies are showing that rural class are also, now the more, in the danger zone of the NCT. The problem with the perception of the patient, for the diabetes, they will definitely go to the private center. And for the tuberculosis, they know that they have a very nearest tuberculosis center.
No, I'm with you.
So there are two dimensions.
Yeah.
If someone is, like the test which you were mentioning, it is a pilot project which was actually happening
that's right.
in the 200 districts. When the people are actually screened, they didn't go to the DM hospitals for the diabetes treatment. They definitely go to the private. And the letter which was sent to all the ministries, all the health workers or health officials, was not went to the private.
No, you're quite right. No, it's a very good observation. And I think more work needs to be done in this area, actually. Yeah. But there
So
is.
we have just about 4 minutes left, so I just want to make sure everyone has gotten a chance to ask all your questions. Anyone else with a question before we wrap up? Good job.
Okay.
Thank you so much. I actually have a quick question, because you talked about the possibility of isoniazid preventive therapy for people who have diabetes. But if you look at a country with such huge numbers of diabetics, it doesn't seem possible. I mean, financially, economically,
No, sure.
it's, is that something that's actually being considered?
No, so I raise it because it was raised in this expert meeting, Linda, but in fact it's not, right? I think most people think probably the way to control this is to make sure we identify people with diabetes and we control their diabetes. And by controlling their diabetes, we will stop, hopefully, the risk of TB. Yeah?
Yeah.
So I think it's the same as HIV. The way to stop HIV infected people getting TB is probably to give them antiretroviral treatment.
Right. Well,
Control.
thank you so much.
Pleasure.
One of the most interesting sessions.
Yeah.
Okay,
No doubt.
well, thank you.
Yes.
Very nice. Well, nice to chat to you.
Okay.
I've already given you excellent on my.
Yes.
Oh.